Very good morning to all of you, and good afternoon and good evening to all of us who are joining from the rest part of the world. Today, our guest speaker for the day is no other than Dr. Mukesh Desai from Mumbai, and he's going to lecture us on therapeutic armaments in inborn error of immunity. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Lucian Life Sciences, and very well managed by Perfect Square. I thank Mr. Srivastava and Team Lucian, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Ankur Jindal from Bangalore, our guest speaker for the day, Dr. Mukesh Desai from Mumbai, all our discussants who are themselves very eminent adult as well as pediatric hemato-oncologists, and you participants for spending a Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give you a flavor of our next weekend activities. Next Saturday, that is 23rd of August 2025 from 7 p.m. Indian Standard Time and 9:30 a.m. US Eastern Time, we have Dr. Talha Badal from Florida speaking to us on upfront immunotherapy in ALL. And the following day, that is Sunday, you've got 3 webinars. The first one is at 10 a.m. by Dr. Gopinathan on mantle cell lymphoma, navigating through biological heterogeneity and management in 2025. Followed by that, at 11:30 a.m., we have Dr. Lieutenant Colonel Dr. Ranjit Matthew Varghese from Pune speaking to us on non-fragmented approach to fragmentation hemolysis, case-based approach. And followed by this, at 1 p.m. Indian Standard Time onwards, we have Dr. Ramesh Balasubramanian from Madurai speaking to us on clofitamab regimen improves survival in large B-cell lymphoma. Let me introduce our discussions for the day, and we have galaxy of them here displayed in alphabetical order. I will pause for a while for you to have a look on all our discussions for the day. These are very eminent hematologist, hemato-oncologist, adult as well as pediatric hemato-oncologist all over the country. So these are our discussions for the day. And now it's time to introduce our guest speaker for the day. We have no other than Dr. Mukesh Desai from Mumbai. We all know Dr. Mukesh Desai very well, but it's my formal duty to introduce Dr. Mukesh Desai to all of you. Dr. Mukesh Desai is hematologist and immunologist, professor of pediatric hemato-oncology, chief department of inborn errors of immunity at BJ Wadia Hospital for Children. He's also the consultant hematologist at Max Nanavati Super Specialty Hospital. His special interest lies in primary immunodeficiency disorders, that is inborn errors of immunity. He has obtained training at Great Ormond Street Hospital, London, Hospital Enfant Mayaris Necker, Paris. Advisor to WHO at Myanmar 2003. He is also the recipient of J.G. Parekh Oration and D.B. Shirol Oration. Today he is with us and is going to lecture us on therapeutic armaments in inborn error of immunity. But before he does that, let me introduce our special guest and chief guest for the day. We have with us Dr. Ankur Jindal from Bangalore. Let me introduce Dr. Ankur Jindal to all of you. Dr. Ankur Jindal is clinical immunology and rheumatology specialist, MAMS, associate FAMS, consultant pediatric clinical immunology and rheumatology at Manipal Hospitals, Bangalore. He is former associate professor of pediatric clinical immunology and rheumatology at PJ Chandigarh. He is also the Angioedema Center for Reference and Excellence Steering Committee member, APSID Junior Members Working Party Country Representative from India from the year 2020 to 2024. He is also the ESID Junior Country Representative from India from the year 2022 to 2024, founder member and General Secretary for Hereditary Angioedema Society of India from the year 2021 to 2027. He is also the Joint Secretary for Indian Society of Kawasaki Disease from the year 2020 to 2022. It's my privilege to welcome and invite Dr. Ankur Jindal to inaugurate our webinar and give some words of wisdom. Well, thank you so much. I stop over here. Over to you, Dr. Ankur Jindal.
Thank you so much, sir, and thank you so much for this kind introduction. It's an honor and a pleasure to be here and Special thanks to Dr. Agarwal for inviting me and the entire Mumbai Hematology group. It's an honor to share the stage with my friend and my colleague, Dr. Mukesh Desai. We know each other for many years. So my job over here is to talk to you about intricacies of medical life, difficulties faced and rewards achieved in next 3 to 4 minutes. And I would say that these are my personal opinions, my views, and based on my own journey and experiences that I have encountered in last approximately 20 years since the time I have been into medical profession. So this slide gives you a brief overview of my journey. I was born in a very average middle class family in Haryana with no medical background, and that's I think the situation with many of us. Nobody in else is the doctor in your family, and then you out of nowhere decide to become a doctor. So I would say it was an accidental choice that I chose to become a doctor. But I would say that it was still a choice, and I decided to stay with my choice. I think I never ever regret on deciding to become a doctor. After doing my graduation from Jaipur, then I again chose to become a pediatrician. So that was again by choice. I had all possible options available to become a radiologist, to become a dermatologist, but that was a choice, that you make during your journey. And the reason why I wanted to do pediatrics because I wanted to pursue my careers into a very niche branch, something like pediatric clinical immunology and rheumatology. And that's what I ended up doing. My DM that I finished in 2018, and I served as a faculty in the same department in PGI Chandigarh for almost 7 years. And again, I chose to quit from there and then joined as a senior consultant recently in Manipal Hospital, Bangalore. So what I learned and the messages that I wish to convey during through my journey, there is absolutely no doubt that life in medicine is tough, but this is a choice that we make, and there are absolutely no regrets once we make this choice. Not only when we decide to choose medical profession, also throughout the journey of this medical profession, we make several choices at several steps, whether you want to go into academics, you want to choose this particular branch or that particular branch. So these choices are there at several steps. Again, none of the choices are ever wrong. Believe me, you make a choice, make sure it happens, put your heart and soul into it. And that's what we need to do throughout this journey. There is absolutely no comparison with your school friends, your brother, sister, cousins. For example, my brother, who is younger than me, he started earning much earlier than me, and he still, touch wood, he earns more than me. But that's not a comparison that you can ever bring into your life. One more thing that I have encountered during my practice is, people would rate you equivalent to God, but always remember that we are human beings, not God. We are just doing our job, and that's our profession. So the choices that you get to make between is clinical versus paraclinical, academic versus non-academic, institutes versus corporate hospital. But believe me, these are not watertight compartments. Now, being into a hospital or being into a corporate hospital doesn't mean that you can't do academics, you can't do research. You can do as good an academic and as good as research as some, equivalent to somebody who is actually part of being an institute. Throughout this journey, I also realized, at least I realized, that earning money is not a bad thing. We if a film star or a cricketer is earning money, everybody claps. On the other hand, whenever a doctor is earning money, everybody raises the eyebrows. On the other hand, we tend to earn money in a very, very positive, very, very ethical manner. So earning money is not a bad thing. It is just the perception of the society that need to change. Certain things that I've also learned: take care of your health. This is absolutely irreplaceable. You are irreplaceable for your family, so prioritize them. Very important thing is the perseverance. Grilling is part of your medical curriculum. So stay strong. If you think that you are being grilled and if you take that as a burden, that is not how it is going to work. So if you are grilled during your medical training, believe me, you will never ever be grilled anywhere else. And it's a vice versa situation. If you take it for granted, believe me, you will continue to be grilled anywhere and everywhere that you go. Read good books that help develop your personality. Now, what are the rewards that you get? For example, my field, my passion, my dedication is towards angioedema, and that is what you get in the form of this rewards. I now stand into the steering committee of angioedema centers of reference and excellence, which is the highest governing body that looks after so many activities related to angioedema across the world, including many projects, many activities related to angioedema across the world. And I happen to be fourth into the steering committee of this particular governing body. Other rewards, I'm just enumerating just one or two. There are several of those that you get throughout your journey. If you are honest with your work, if you're dedicated, if you are passionate about your work, I don't know whether you know this gentleman with whom I'm sitting and with whom, who also awarded me way back in 2018 when I was doing my training. So this man is Dr. Tomisaku Kawasaki, and he's the one who described Kawasaki disease way back in 2000, way back in 1967. And meeting such people who have described these diseases, who have discovered the name of these diseases, you meet them, you understand a very different perspective, and when you see such patients, you treat them very, very differently. So these are some of the rewards that I mentioned. So I think perseverance, dedication, honesty with your work is extremely, extremely important. And it comes into the form of rewards in many, many different ways. So with this, I would end my presentation over here, and I would hand it over to the organizers and to Dr. Mukesh Desai for his presentation. Thank you so much.
Thank you, Dr. Ankur Jindal. Wonderful words, wonderful the presentation slides you made. It's eye-opening for all of us, exactly what we should do in the future. And when you specialize in certain things, basically when you do hematology, rheumatology, whatever you do, but the important is what you are up to. That's what you brought out today. What should be your goal in your life? Beautiful words, fantastic slides. Thank you so much, Dr. Ankur Jindal, for being with us today as our chief guest. Thank you so much.
Thank you, sir.
And now, Dr. Mukesh Desai, sir, screen is yours. Please go ahead.
Can you see my slides?
No, not yet, sir.
Okay. Okay. Can you see it now?
Yes, sir. Perfect. Please go ahead.
Okay. Let me. Okay. How do I move the slide?
Down the arrow is there, sir.
Okay, here.
Yes.
All right. So thank you for inviting me to talk to you. At the outset, let me thank Dr. M.B. Agarwal and the entire team of Mumbai Hematology Group. My job for today is going to give you a flavor of therapeutic armaments in inborn error of immunity. And I think this is going to be a long talk, but I'll try to minimize it to the very basics and try and give you a flavor of the entire treatment gamut which is available to us. If we really look at what I'm going to present is going to be largely because of the team which I have, my mentor, Dr. Zinat Karimboy, and that we have now 3 full-time staff. And as you can see them over here, I just have the privilege of presenting the work which has largely been done by them. And through their interaction, it's always a pleasure to learn something more every day. Friends, why is it so important to make a correct diagnosis? Let me illustrate that with this particular case. This is a doctor himself. At the age of 43, he came to me for a neutropenia. He's already seen 2 hematologists, and they have done twice bone marrow with cytogenetics and labeled him as a unilineage cytopenia, myelodysplastic syndrome. He responded to GCSF and was doing well, but like a typical doctor, he never took his medication seriously and came back to me with severe neutropenia. When I was taking his history, I had a history where he told me he's been having oral ulcers right from when he can remember, very early in his childhood. And on inquiry, when I asked him, have you undergone any heart surgery? That's the time he told me he had been operated for atrial septal defect. The history of oral ulcers and stomatitis very early in life told me that probably we are dealing with a congenital neutropenia. And an ASD told me that probably we are dealing a syndromic cause for congenital neutropenia. And we clinically suspected a diagnosis of glucose 6-phosphatase deficiency. We got his exome done, which confirmed the diagnosis. And the beauty of making this correct diagnosis was that we put him on an anti-diabetic, Jardiance, and within 2 weeks, his absolute neutrophil count, which used to be less than 70, went up to 4,800. So this is the power of making a very correct diagnosis. And I think this is very, very important that making a correct diagnosis may sometimes give you a clue or may give you a pathway which you can target for treatment of this patient. Where have we all come in the story of inborn error of immune deficiency is illustrated by this particular child who came with a CMV pneumonia. He was on a ventilator, came out of it, and we asked this fundamental question, why has this child developed a CMV pneumonia? On workup, he turned out to have hyper IgM syndrome, and we could do the workup at NIH, where it was confirmed that he had a CD40 ligand deficiency, and subsequently, he could be sent for a bone marrow transplant at Valley Children's Hospital, and he was ultimately cured of his disease. So this is the story of inborn error of immune deficiency in India, and this story is very rapidly changing with new therapeutic armament which is available to us. If you look at the IUIS classification 2024, friends, you would realize that when we started in 2007, there were less than 100 or 120 disorders of inborn error of immune deficiency. Today, there are more than 555 inborn error of immune deficiency, and this is expanding very rapidly. And here you can see the subgroups in which you can actually divide them and slot them into. So the principle which we use for diagnosing and evaluating patients of inborn error of immune deficiency is very simple. If anybody comes to us with any illness, we go beyond the immediate diagnosis and ask, why has this child developed this problem? If we don't know the disease, we try to establish a plausible pathophysiological diagnosis, and both this process very often lead us to the underlying cause. Say somebody comes to you with a pneumonia, we ask, why has this child developed pneumonia? And that takes us to the inborn error of immune deficiency. Other principles which we follow is that genetics of infectious disease is more the norm than exception. That means if anybody comes to you with a very severe type of infection or an unusual infection, then one would look for an underlying inborn error of immune deficiency. One principle which we follow, which my mentor, Dr. Karim Moy, used to always say, that patients don't read our books and journals, so they can present in any way. So keep your mind open to all possibility. And one simple principle which we follow is that not everything in inborn error of immune deficiency is yet discovered, and there's a lot which needs to be discovered. So for all of you, you have a tremendous scope to further your, as Ankur has already highlighted for you, that how your passion can lead you to further progress in this particular disease. This is just to show you that we had 853 exomes done where you had large number of primary immune deficient diagnoses at Children's Hospital. So in the next few slides, let me take you through the evolution of clinical, pathophysiological, diagnostic, and therapeutic approach to inborn error of immune deficiency. We all know that infections can give you a clue to the underlying immune deficiency, as you can see by this type of infection. Generally, we believe that whenever somebody gets infection or there is an immune deficiency, there is an infection in the broad repertoire of infection organism. But there can be immune deficiency where you could have infection with limited repertoire of infection, like IL-23 defect, where you are prone to getting Mycobacterium tuberculosis or atypical mycobacterial infection. Or you have Th17 pathway defect, which makes you susceptible to chronic mucocutaneous candidiasis. Today, we also know that one example of that is that fulminant Hep A is because of an IL-18 binding protein defect. Secondly, we all believe that the immune system having arisen from the hemopoietic system would be restricted to hemopoietic immune deficiency, while now we know there are examples where you could have immune deficiency in extra hemopoietic organ, and a classical example of which is an EVER1, EVER2 deficiency, which results in susceptibility to getting warts, which is because of EVER1, EVER2 deficiency in the keratinocytes and not in the hemopoietic system. We all know that complement system deficiency, properdin and C5 to 9 deficiency is being produced in the liver and not in the hemopoietic tissue. As I told you, as we understood inborn error of immune deficiency better, today we know that not only one gene can cause one disease, but one gene can have multiple phenotypes, or a multiple clinical phenotype can have a single gene defect. So here is an example of a RAG1, RAG2 deficiency coming to you with either severe combined immune deficiency, T negative, B negative SCID, or EBV lymphoproliferative disorder, or it can come to with Omenn syndrome and granulomas. So one gene causing multiple clinical phenotypes. And here is an example of all the genes which can result in susceptibility to mycobacterial disease as shown in this cartoon. So multiple clinical a multiple genetic defect leading to one clinical phenotype. Another example of TH17 pathway defect leading to CMC or chronic mucocutaneous candidiasis is once again giving an example of multiple multiple genetic defect with one clinical phenotype. So today's main talk is going to be on the treatment, which is going to be the supportive interventions, hemopoietic stem cell therapy. Now we have precision medication targeted at biochemical and cellular defect, and molecular therapies, including gene therapy. So this is just to show you the timeline of evolution of treatment in inborn error of immune deficiency. The first hemopoietic stem cell transplantation was done in 1968 for X-linked recessive severe combined immune deficiency, followed by ADA SCID. Then you have various manipulation of the immune of the bone marrow graft. Then the first thymic transplant for D. George was done in 1997, and further progress, as you can see in the upper line. And then from 1987 onwards, we have an FDA-approved enzyme replacement therapy for ADS kit. Then you have IL-1 antagonist for autoinflammatory disease, abatacept for CTLA-4 deficiency or for LRBA deficiency. Then we have small molecular inhibitors for like PI3 kinase delta inhibitors in APDS syndrome. Then we have the JAK-inhibitors, which are used for STAT1 and STAT3 gain of function, and many other biologicals which are now available, which I'll allude to you very quickly. So let me run through this slide, which show you the type of cytokine inhibitors which are available to us, like the IL-1 inhibitor, but the classical example of understanding the pathophysiology and using an appropriate cytokine is the interferon gamma, anti-interferon gamma antibody, that is emapalumab. Then we have various targets of manipulating the immune B cell and the antibody production, as you can see over here, which I'll again allude to a little later. And this I've already highlighted. We not only have an anti-IL-1 receptor antagonist, but we have anti-IL-1 beta antibodies with longer half-lives, which can be used less frequently. And these are just the small molecular inhibitors, which I've already alluded to. So this is what I'm going to show you some examples, and we'll discuss some aspects of treatment, as you can see, in various types of immune regulatory and immune deficiency disorders, which we have come across in clinical practice. So coming to cellular therapy, the most definitive treatment for certain immune deficiencies is a hemopoietic stem cell transplantation. But before the child can go for a hemopoietic stem cell transplantation, the pediatrician or the primary care physician has a tremendous role to play. All our children have received BCG, so they should receive an AKT prophylaxis if you have a suspicion of SCID, or if they have BCG-osis and a full AKT. An antifungal cover is very important because they are prone to fungal infection. Covering CMV, giving CMV prophylaxis if CMV is not very important with ganciclovir, and a PCV prophylaxis with IVIG need to be given to this patient. In case you have to give blood and blood product transfusion, please irradiate them if you are suspecting a severe combined immune deficiency. Please do not give them live vaccinations, and make a very quick referral once you confirm the diagnosis, or even before you confirm the diagnosis, to the bone marrow transplant team. Then they can do an HLA typing and search for a donor, and then subsequently take the patient up for transplantation. So just to show you an example of a child with BCGosis was diagnosed as kid, and another child who was an epsilon chain defect underwent a transplantation, came to us with chronic mucocutaneous candidiasis, post-transplantation developed a BCG flare, that is because of reconstitution syndrome following a hematopoietic stem cell transplantation. This child ultimately got cured of his transplant, of his kid. So here are some of the indications in inborn error of immune deficiency for hematopoietic transplantation, those where it is definitely curative, where it is partially curative, and where it is controversial. So among the partially curative, you must know that some of these disorders may have manifestation outside the hematopoietic system. So the hematopoietic stem cell will correct the immune deficiency, but the other systemic involvement will not be corrected. And I think this is important for us to realize. One of the classical example is the Fanconi's anemia, which the bone marrow part can be cured, the bone marrow failure part can be cured, but the rest of the systemic involvement cannot be cured. Another example of which is your GATA2 deficiency, where the hematopoietic system problem can be cured, but the lymphedema and other problems cannot be cured of this by a hematopoietic stem cell transplantation. Among the controversial indication is like indication for a B cell defect like A gamma globulinemia. I think in the West, they would prefer to continue giving IVIG because the cost is not a major consideration for them. But in India, I think Dr. Revati and other people are trying to do transplantation for patients of A gamma globulin CVAD. This is the kind of data which will only come from India, which I think we should be aware of. And this could be our contribution to the field of inborn error of immunity therapeutics. This I've already shown you as CD40 ligand deficiency is definitely an indication for transplant. Somebody who presents with a very early onset IBD, as in this child with anal fistulas and perianal fistulas, I think it is important to realize the deficiency of IL-10, IL-10 receptor, though they may not have a hematopoietic component, can be cured by doing a bone marrow transplantation. I've already alluded to GATA2 deficiency. You cannot cure the other aspect, but the hematopoietic and the immune system can be reconstituted by transplantation. This is an interesting story of a child who came to us with a chronic mucocutaneous candidiasis. On evaluation, we found he had a gain of function STAT1 defect, but he also had a defect in GATA2. So we evaluated the mother. Mother had a GATA2 mutation and she was anemic. And on investigation, we found that she had a very low NK cell, she had a very low CD3, CD4, telling us that she is already clinically having manifestation, but she was not willing to go for a transplantation. We didn't go for transplantation. We lost her because of progression to an acute leukemia. So I think this is very important for us to understand that doing family studies, you can pick up sometimes a symptomatic or undiagnosed patient, and we need to treat them and cure them. The elder SIB also has a GATA2 mutation, and we are trying to convince the family that as the SIB becomes symptomatic, we need to probably transplant the baby. Children with gain of function STAT1, as in this case, can be cured of his, but other systemic manifestations cannot be cured by hematopoietic stem cell transplantation. The same story of an APDS syndrome over here, but this patient who came to us with 2 episodes of EBV positive lymphoproliferative disorder, wrongly diagnosed as lymphoma, but we could not transplant him because he had severe EBV viremia and he had hemorrhagic chickenpox, because of which we could not send him for a transplantation. Patients of blockade deficiency do very well with hematopoietic stem cell transplantation, and patients of LRBA deficiency and CTLA4 deficiency, if diagnosed early, can do exceedingly well with transplantation. After you have probably controlled the autoimmunity and other aspects with abatacept. I think what is important over here to realize is that for patients of CTLA4, you could have a donor in the family who could be an asymptomatic haploinsufficiency of CTLA4. So it's important that the donor also should be tested for the possibility of an asymptomatic stage of CTLA4 deficiency, so that we don't use him as him or her as a donor in case they use a family donor. Patients of C1q C1q deficiency will be cured with bone marrow transplantation. DARA2 deficiency can also be cured with transplantation, and there are initial reports which show that some of the manifestation of vasculitis can also be reversed by bone marrow transplantation. It is important for transplanter also to know that if you are having an inflammosomopathy, then you must know what is the source of production of IL-18, which is the source of the inflammatory cytokine. If it is the gastrointestinal epithelial cell, you must know that doing a transplant in such a setting will not cure your patient. Patients of ZAB deficiency very often come to you with an HLH, though it is named as an XLP2 or X-linked lymphoproliferative disorder type 2. They have a lot of autoinflammatory manifestations, and somehow they don't do well with, or their outcomes are not so good with hematopoietic stem cell transplantation. In fact, we need to use some drugs which are now going to be tried, quercetin, which is a natural flavonoid, which can be used for bringing down the autoinflammatory manifestation of ZAB deficiency. Patients of X-Men disease have susceptibility to EBV. For some reason, with transplantation, they don't do exceedingly well. So you must select your patients carefully and evaluate them carefully before you take them up for transplantation. Coming to gene therapy, which is a very important thing, and I think in India, there's a gentleman who is planning to do a gene therapy trial for ADS kid. And this is the timeline in gene therapy, which tells you that in 1968, where the first hematopoietic stem cell transplantation was done, the first gene therapy trials were done in 2000, and it was Alan Fisher's group who tried and did the X-linked kit. But the biggest problem which they faced was of insertional mutagenesis and development of leukemia in this patient. Had that been a success story completely without the insertional mutagenesis, gene therapy trial, Alan Fisher from Paris would have probably been in line for a Nobel Peace Prize. In 2023, 23 years after the first gene therapy trial, you can see that there is a follow-up of almost 23 years with that. So these are some of the defects for which gene therapy trials are available. And the only thing which is approved is the ADA-SCID gene therapy, which has been approved by FDA. Rest all are yet in the experimental stage. Some of them in advanced, some are in animal model, but I'm sure in future we'll hear more about gene therapy as we can have better vectors which are available to us. So is there an enzyme replacement therapy? As I told you, for ADS kit, we have enzyme replacement therapy available. Now, one very important thing which is the role of thymic transplantation. So for DGeorge, a severe DGeorge syndrome, and I'm sure immunologists would agree that we are probably missing out large number of DGeorge syndrome, which are phenotypically not obvious and who have a lot of autoimmune problems. Those DGeorge with a very severe lymphopenia, with a very atrophic thymus, needs transplantation, thymic transplantation. You have a nude mice FOXN1 phenotype, which can be cured by transplantation. And those patients who have PAX1 deficiency, which is a defect in the thymic epithelial cell, rather than in the hematopoietic, which present as severe combined immune deficiency, and sometimes they may have autofacial cervical syndrome. I think it is very important to realize that once you make this molecular diagnosis, it will give you a clue that this patient will not get cured with hematopoietic stem cell transplantation. Though their presentation is like SCID, they're more likely to get cured with thymic transplantation or a combined hematopoietic stem cell and a thymic transplantation. Some of the SCID patients may require combined hematopoietic stem cell and thymic transplantation, and I think this is being explored more and more. I'll quickly run you through the most common inborn error of immune deficiency, hypogammaglobulinemia, which you see, or agammaglobulinemia, where IV gamma globulin replacement therapy is available for treatment. So large number of molecular defects can come to with agammaglobulinemia or CVID-like presentation. And well, important from a pediatrician's point of view is to give them prophylaxis to prevent infection. So AC prophylaxis and septra prophylaxis reduces large number of respiratory infection. As far as vaccination strategy is concerned, use inactivated poliovirus or injectable poliovirus vaccination. Don't give them oral polio vaccination. IVIG remains the mainstay, whether it's given IV or subcutaneous, or you use a facilitated subcutaneous immunoglobulin therapy. You need to give them every 4 weeks. There are special situations like enterovirus infection and parvovirus infection where you require to augment your delivery of IVIG and give higher doses till these viruses are controlled. Because patients of agammaglobulinemia are particularly prone to getting infection with enterovirus and parvovirus. Which of the IVIG is better? I think in India, almost 95% would be receiving IVIG. A very small proportion will receive subcutaneous immunoglobulin. The advantage of subcutaneous immunoglobulin is that you need not visit the hospital and travel time is prevented, but it is relatively expensive and requires very frequent administration. Facilitated hyaluronidase is also once again home therapy, expensive, not yet available in our setup. You must also appreciate that some inborn error of immune deficiency may have normal immunoglobulin levels, but may have functional antibody deficiency, as can be seen here. If they have clinically infection which fit into an antibody deficiency profile, one would give them antibody prophylaxis with IVIG, as we can see. Enterovirus infection require weekly IVIG for almost 6 to 12 weeks till the virus is cleared. And patients of parvovirus infection may require daily IVIG till the parvovirus become negative and for 2 additional doses of it. Some patients paradoxically develop nodular lymphoid hyperplasia, and you may use rituximab in patients of hypogammaglobulinemia to knock out some of this, because these are the harbingers where they would progress to developing a lymphomatous process. Is there a role for hematopoietic stem cell transplantation for agammaglobuline? The answer is probably going to come from India. I think with myeloablative hematopoietic transplantation, there is better reconstitution of the B cell and need for India to generate this data. I think Dr. Revati Raj and a lot of people are generating this data, where you may send an agammaglobulinemia or a CVID for a bone marrow transplantation. Coming to another major group of disorders which we come across, inborn error of immune deficiency, is chronic granulomatous disease. And how do we manage them? Once again, antibody prophylaxis and antifungal prophylaxis. So Septran for antibodies and itraconazole for antifungal infection. Except BCG, this patient can receive all vaccination, and bone marrow transplantation is curative in majority of these patients. Gene therapy trials are also available for CGD, but not available in India for us. One important thing which we must consider is the role of steroids in patients of CGD. So here is a child who had an aspergillosis with Klebsiella pneumonia with left pulmonary vein and left atrium infiltration. He was in a very critical state. We had received almost 3 to 6 months of anti-aspergillosis therapy, and still his conditioning was worsening. And this is a time when once you have ruled out infection and there is a lot of inflammatory component, it may be worth using the good old steroids, which was used for this patient. And this patient probably survived because of steroids, which controlled the inflammation, and his respiratory system improved, his oxygenation improved. Aspergillosis management in CGD is very important. I think we have to understand that CGD patients are particularly prone to aspergillosis, and this is an indulating aspergillus infection, and you need to give them voriconazole at a higher dose for longer duration, for almost 6 months to 3 months, and make every attempt to make a diagnosis of aspergillosis in this patient, including sometimes an incision and drainage of an abscess And this is very, very important because almost 80 to 100% of our patients of CGD had some form of aspergillus infection. Well, this is the indication for stem cell transplantation. If your patient of CGD has no superoxide formation, he should go for an early hematopoietic stem cell transplantation. If there's a residual superoxide formation, then you can do at an appropriate time the hematopoietic stem cell transplantation where the matched sibling donor is available. But if the matched sibling donor is not available or mud is unavailable, then you should go in for an autosomal recessive CGD, haplo or minimally mismatched unrelated donor transplantation, or go for experimental therapy like gene therapy. Is there a role for interferon gamma? The answer is probably no in CGD. There was an excitement about pioglitazone, an anti-diabetic drug in CGD, but it has not stood the test of time. Mendelian susceptibility to mycobacterial disease is a major problem in India, and I am sure that we need to talk about how we treat them. So besides the prolonged anti-tuberculosis treatment and with NTM cover, there is a role of interferon gamma and interferon alpha in this. Regarding vaccination, BCG should be avoided in all IL-12/23 interferon gamma loop defect, while all live vaccination should be avoided in interferon gamma receptor 1, interferon gamma receptor 2, TAT1 and IRF8 deficiency. These people are also prone to salmonella, so you need to evaluate them for salmonella infection and also for antifungal prophylaxis like itraconazole in patients who have IL-12 receptor beta-1 deficiency. LOBMT is curative in complete deficiency of interferon gamma receptor 1 receptor 2, but there are high incidence of relapse in this patient. For recurrent salmonellosis, there may be a role of cholecystectomy. So friends, just to show you quickly, a child with an interferon gamma partial dominant defect, and you can see a BCGosis ulcer. This is a patient shared by Dr. Kumar Ratne from Cambridge. And after giving interferon gamma, complete clearance on histology of the BCGosis as well as clinical healing. I will show you two patients of Mendelian susceptible mycobacterial disease treated at our department with interferon alpha. And this is a patient of partial dominant interferon gamma receptor showing an excellent response only after addition of interferon alpha. And we are trying to continue interferon alpha for a longer duration so that she continues to deal with it. I'm going to skip the story for you. And this is a child, another IL-12 receptor beta-1 defect with nocardiosis, who did very well with interferon alpha 2B treatment. Is there a need for antifungal prophylaxis in patient of MSMD? The answer is patient of IL-12 receptor beta-1 and ROR gamma-3 have very high incidence of candidiasis, and it would be worth giving them antifungal prophylaxis. Coming to phagocytic defect, I think for severe congenital neutropenia, GCSF remains the answer, but if there is a high dose of requirement of GCSF or there is a mutation or secondary mutation happening in GCSF receptor 3, then you should consider hematopoietic transplantation early. Once again, just to show you a timeline on which the various defects of congenital neutropenia was discovered. And this is a publication by Dr. Prashant on use of Jardiance in patient of glucose 6-phosphatase 3 deficiency with dramatic response, which I've already shown in a previous patient. Patients of leukocyte addition deficiency, there are more than 74 patients which have been reported from India. And it is worth knowing that doing an early allo bone marrow transplantation is curative in this patient. We will discuss about role of two cytokines, IL-17, and role of neutrophil transfusion in this patient. So is there a role for a neutrophil transfusion? Probably in a very critically ill patient with multiple perforations of the GI tract, we had used neutrophil transfusion, but unfortunately we lost the patient. I don't know whether the exogenous neutrophil will be able to exude out because the defect is in the endothelial lining and in the exocytosis of the patient. Ustekinumab or an IL-17 blocker can bring about a dramatic improvement in patients of LAD because it is believed that IL-12/23 is the one which drives the Th17 pathway, and that needs to be inhibited by the neutrophil apoptosis. But because in LAD you cannot have neutrophils come to the site of infection, very often there is excess of Th17 pathway which results in inflammation. And here is an example of a patient of Dr. Amita Agarwal who came with such large cutaneous lesions and ulcers, was treated with secukinumab, and you can see complete healing of this ulcer, telling us that yes, it is a good treatment available in some patients of partial LAD, but ultimately this child would require a bone marrow transplantation. Coming to autoimmunity as an important manifestation of inborn error of immune deficiency, these are the various immune defects which can result in various forms of immune dysregulatory disorder. So patients of LRBA deficiency, patients of CTLA4 deficiency can come to you with Ivan syndrome or multiple autoimmunity as is shown over here. And you must appreciate that both LRBA and CTLA4 are haploinsufficient, are phenocopies of each other, and they both have very similar presentation. This is a boy at 37 years who had very early an IBD-like manifestation and a lymph nodes which was biopsied, which progressed to Hodgkin lymphoma. He was EBV positive and subsequently diagnosed as CTLA4 deficiency. So a CTLA4 agonist like abatacept will be the treatment of choice for this patient to control the autoimmunity and the hypogammaglobulinemia, which very often they have. They would need IVIG replacement, and subsequently, if there are matched sibling available, should go for a bone marrow transplantation. As I told you, patients of CTLA4 deficiency can have an asymptomatic sibling, so the sibling should also be tested for an CTLA4 haploinsufficiency before is considered for as a donor for transplantation. So this is just to show you the various aspects which need to be taken care of in patients of CTLA4 deficiency. Well, this is a patient of very early onset IBD with ITP and with alopecia areata. And this patient was transplanted to Vadia Children's Hospital. He was initially put on abatacept and sirolimus. Dr. Stephen Holland's group has tried hydroxychloroquine in patients of LRBA deficiency. It has more promise in theory, but we haven't yet found any significant improvement in our patients. In those patients who have a nonsense mutation, a premature termination, you can use etaluren, which is a translation read-through inducing drug, and this can complete the translation process and allow production of LRBA and can ameliorate the symptoms. This has also been tried in various other immunodeficiencies, as can be seen over here. So there are these newer therapeutic armaments which would soon be available to us. Now, this story of a child with gain of function STAT3, this is a boy who came to us with severe thrombocytopenia, lymph nodes, liver and spleen. So he had autoimmunity, he had Coombs positivity, and he also had lymphoproliferation. When we got a molecular diagnosis of gain of function STAT3 deficiency, we tried initially IL-6 receptor blocker tocilizumab, and his platelet count, which was 1,000, dramatically improved to 126,000 in as short time as 5 to 7 days. So this was a dramatic response to tocilizumab. But since he could not afford to continue tocilizumab, we gave him a we put him on ruxolitinib, JAK2 inhibitor, to which he showed a dramatic response to the point that a child who was having an autoimmune hemolytic anemia actually became polycythemic, and we had to bloodlet him. So if you have the correct diagnosis, if you can use the correct blocker, you can get a very dramatic response. He is now on 6-7 years of follow-up with us, where in between we are giving him a holiday from drug because ruxolitinib is expensive. During the COVID, when baricitinib was cheap, we shifted him to baricitinib, and he did exceedingly well with that. Now we have again shifted him back because baricitinib again become expensive compared to that. So these are the various targets which can be used in gain of function STAT3. As you can see, the JAK inhibitors can be used, IL-6 receptor blockers can be used. You can use mTOR inhibitors like sirolimus and so on for this side. Patients of ALS, the classical drug to use is rapamycin or sirolimus, and it works wonders for these patients. Patients of APDS syndrome, as you can see over here, a girl with severe lymphoproliferation, IBD like manifestation, EBV infection, adenovirus infection. These patients can do very well with sirolimus. As you can see over, we can target sirolimus, the mTOR pathway, or we can use a specific inhibitor of PI3 kinase, the leniolisib or idelalisib, and their trials have already been done with good response to that. And I think we should be aware that you can target a lot of this specific pathways which can help us cure. Patients of trichohepatic centric syndrome have dysregulated cellular RNA, which results in activation of the mTOR pathway, and sirolimus is a good drug to control the hyperactivation. And here is just to tell you the story of this child who came to us with multiple osteolytic lesions and a pleural effusion, and everybody thought that he's got a staph empyema and he's got a staph osteomyelitis. And I just want to particularly share this disease because it is our team and our fellows who actually worked out the diagnosis of Graham-Stout syndrome when they realized that this patient was having severe lymphopenia. A diagnosis of SCID was considered. A pleural tap with its analysis of lymphocyte subset analysis showed that the lymphocyte were actually getting into the pleural fluid, and that's why there was a peripheral blood lymphopenia, while the pleural tap fluid was showing a normal lymphocyte count. And that's when they suspected a Graham-Stout syndrome. They did the VEGF level, which was very high, and put the child on sirolimus with complete clearance of effusion, osteolytic lesion. So this is just to tell you that, as Dr. Karim Boy had taught us, that first establish the pathophysiological process. It will give you a target as to what to target, and probably not only help you in making a diagnosis, but also give you a therapeutic target and a means of monitoring, which is now possible in our country. And I feel so proud of our team that they could not only establish the pathophysiological process in this particular child, make a correct diagnosis, and then go on and use the hypothesis, use the drug like sirolimus, and show a complete response. That was something which was very heartening to me, and I thought that probably now I have made myself redundant, and I should hand over all the functioning to our younger chaps who are there in our department. So here is just to show you that SPEN-CD and interferonopathy, like an Aicardi-Gouttière syndrome, does extremely well with JAK inhibition. So JAK inhibitor is a new drug, a wonder drug for a lot of immune deficient patients. Just like an Aicardi-Gouttière syndrome, which is nothing but an interferonopathy like lupus, JAK inhibition along with an antiretroviral therapy could be a very important target for primary immune deficiency syndrome. So this is a presentation which was done by Dr. Rafaela Mensky, and you can see over here, she had made a diagnosis of Lin gain of function. Just like that, you have SRC gain of function, which respond beautifully to dasatinib, a drug which we use for patients of chronic myeloid leukemia. Patients who have WHIM syndrome because of an gain of function mutation in CXCR4 can be treated very effectively with plerixafor. So just to tell you that understanding the pathophysiological mechanism can bring about dramatic improvement, and there are now molecules available which you can use to target patients. In patients of Rosai-Dorfman disease, here is a patient who subsequently was diagnosed as H syndrome. Initially, we treated him with sirolimus with a very good response. He was published. Later on, we had a molecular diagnosis. And then considering that H syndrome, there is an increased activity of IL-6 pathway, we put him on tocilizumab with now near complete regression of his lymphadenopathy. And he's doing exceedingly well on tocilizumab weekly or every 2 to 4 weeks. EBV virus related lymphoproliferative disorders can be targeted by using rituximab, as you can see in this patient who had lymph nodes for almost 3 years, and by giving rituximab 4 doses of complete clearance. But like how you say, picture abhi baki hai, this patient had a relapse and would not respond to R-CHOP and would have a further relapse, once again showing that she did not have any genetic mutation, telling us that you probably need to do more to find, because she definitely is immune deficient, having susceptibility only to EBV, doesn't have the known genes which make you susceptible to EBV. And this is a patient who needs to be worked up to find out a new genetic defect, probably to contribute. This may be your contribution to the world of progress. Another story of a boy who came to us with molluscum contagiosum, and this is a child who was diagnosed with X-Men disease. He didn't have EBV. Fortunately for him, later on during follow-up, he handled the EBV very well, and he was treated with magnesium supplement, which showed an improvement in expression of NKG220 and NKG2D, and his molluscum completely disappeared, as you can see over here in some of the pictures. So this just shows you that, you just a little innovative thinking, a simple drug like magnesium in X-Men syndrome can improve the child's condition. He is doing exceedingly well, especially because these children don't do well with bone marrow transplantation. Now, this is a very famous slide which is shown by Dr. Stephen Holland, where he shows a lot of auto antibodies to cytokine or cytokine antibodies presenting with various phenocopies of inborn error of immune deficiency. And just to tell you that some of these patients can have an MSMD if they have an anti-interferon gamma antibody, and they can be targeted by rituximab or a host of targets which are available. I think among the targets which are available to us is you have rituximab, you have obinutuzumab, you have Velcade or bortezomib, which can be used. You have daratumumab, which can be used for some of these autoimmune phenomena, which I think is very important for us to realize. Well, this is to show you patients of Chapel syndrome or CD55 deficiency who has come to us with a leukocytoclastic vasculitis, responding or do very well with eculizumab, a drug which we use for TTP. Pozelimab is another drug which can be used to target the C5 components of complements with very dramatic response in them. CD59 deficiency, which comes to us with a recurrent Guillain-Barré syndrome or hemolytic anemia, can also be targeted with eculizumab. Very interestingly, most oncologists now use a lot of PD-1 and PD-L1 inhibitors in patients of Hodgkin's lymphoma and other types of lymphomas and malignancy. So, immune activating drug like nivolumab can be, or a PD-1 inhibitor can be used even for controlling or activating immune system to control slow virus infection like JC virus infection. And inhibition of this reinvigorates the JCV specific CD4 positive and CD8 cell, and this has been shown very elegantly by Stephen Holland's group. So you have this armamentum which is still available for you. Now, you all have heard of an inherited inborn error of immune defect or monogenic defect. Now we are talking of somatic mutations which can, in the inborn error of immunity genes like UBA1, which present with Vexus syndrome. And Vexus syndrome is now an adult autoinflammatory disorder, and they can be associated with MDS. And we can use various therapies for patients who come to us with Vexus syndrome, like tocilizumab. We can use azacitidine if they have an MDS-like presentation, and we can use anakinra or anti-TNF alpha therapy for Vexus syndrome. So there's that whole gamut. We have to find the right indication for this patient in this situation. Now, coming to the last part of my presentation, I'll tell you the story of a boy who was working at Tata Memorial Center, who presented with tuberculosis of the terminal ileum at 16 years. He had lymph node tuberculosis, esophageal candidiasis, CMV colitis, and E. coli sepsis at the age of 26, herpes zoster at 22, severe COVID infection, and he had an EBV-driven lymphoproliferative disorder at the age of 35 years. Also had recurrent fever, weight loss. That's the time he was presented to us. He had a severe pan-hypogammaglobulinemia and a severe T-cell lymphopenia. He was treated with rituximab. We had done an exome to look for underlying immune deficiency, but he had no monogenic defect which we could identify. Then he came to us with cervical and abdominal lymphadenopathy. On evaluation, there was this dilemma whether this is Hodgkin lymphoma or an EBV-driven lymphoproliferative disorder. And that is the time when we realized that let's give him rituximab. He was given rituximab. He did well. And since there was this big dilemma going for a long time, his only consistent thing was he was having severe lymphopenia. And all the pathologists got together and they decided that this is probably a Hodgkin disease and treat him like a Hodgkin disease. Since this was like a Hodgkin lymphoma, we didn't want to give him chemotherapy because he would not have been able to tolerate the chemotherapy. So he was put on nivolumab and he did exceedingly well.
Just a minute. Dr. Shilpi, can you please put your mic off?
Sorry.
Yeah.
So this patient finally was treated with nivolumab and he did exceedingly well. And he became normal. And that was the time where we were trying to convince the transplanters that he needs to undergo a bone marrow transplantation. He needs a new immune system. He is classically an immune deficient patient, even though we are not able to identify his underlying immune deficiency or there's no monogenic defect. But somehow all the transplanters thought that maybe no, he's doing so well, but we couldn't convince them that he needs a transplant. Now when he's well, because his absolute lymphocyte count still remained very low and his CD4 lymphopenia was persistent in spite of patient doing very well. And I think this is the time when he should have been transplanted and probably he could have been cured of his disease. But somehow the transplant was not done because we are not doing the transplant. It is the transplanters who have to take this call. And this patient subsequently developed a CMV pneumonitis, CMV gastritis, enteritis, colitis, severe GI hemorrhage, and he was in the hospital for 4 months. Everybody struggled to salvage him. He was having multiple hemorrhages. He was given a lot of support, but he was ultimately lost him after 4 months of struggle. This case I'm trying to show you to tell you that sometimes you may have no monogenic defect, but you would know in your heart that this is an immune deficient patient. There is enough evidence of that. Even though patient is doing well with therapy, what you have chosen for that particular problem, his lymphopenia is persistent, and that is the main root of the problem. We should tell you that when the patient is well, please transplant him so that we can cure this patient and change the story of this boy from dead in the hospital to being alive and transplanted and doing exceedingly well. I think that risk we have to take. That is something which I very strongly feel. Do it when the patient is well. Don't wait for something worse to happen. Well, this is all the gamut which I have taken you through. And I want to thank you all and thank my patients who have always taught us. Thank my team at Vajra Children's Hospital, who has always been teaching me every day something new. And it's a pleasure to learn from your juniors all the time. And some of the work which I'm showing are very elegantly discussed on the principles which were laid down by our mentor, Dr. Zinat Karimboy. There's still a lot to learn for all of us. And thank you for your attention. Thank you very, very much.
Thank you so much, sir. Fantastic lecture as always. Wonderful slides. You went through a wonderful journey of the inborn errors of immunity. Fantastic, sir. Hats off to you. And I now request all our discussants to please put the hand raise sign so that we can start our question answer session with Dr. Mukesh Desai, sir. In the meanwhile, when the hand raise signs keep pouring, there's one question from Dr. Naresh Tayade. Genetic HLH plus syndrome due to SLC29A3, if it can present with transfusion dependent anemia?
So I want to tell Naresh is that we are as expert in H syndrome as he is. So we always try and learn about the disease manifestation and read up and go ahead and treat this patient according to what we can gather from the literature. Yes, they can present with transfusion dependent anemia. and they can have a huge amount of variation in manifestation and not same H syndrome patient present in the same fashion in the entire family. I think the patient which we had more of lymphoproliferation. In between, he had an HLH-like symptomatology, which you can treat like an HLH, and you can use tocilizumab, which is a good drug in SLC29A3 deficiency.
Thank you, sir. You said about thymic transplantation in CHD7. How does it benefit?
So I'll answer that question when we have next Life at War series, which will be dedicated to thymus.
Thank you, sir. Another question from Dr. Naresh is again MHC class 2 deficiency. What is the treatment?
Bone marrow transplantation is a good treatment for that.
And any role of aminoglycosides in stop codon mutation?
I have no idea about this.
Thank you, sir. Dr. Chepsy, your question.
Thank you, Dr. Desai. Am I audible?
Yes.
Yes.
Yeah, Dr. Desai, you brought about some very valuable clinical points. So this neutropenia is something which is not uncommon in many hematology clinics, and we, like you rightly pointed out, we end up doing a marrow most of the time, label it as unilineage dysplasia. So could you give us some pointers as to us not closing the story on such patients and try to pursue an inborn error of immunity in such patient from their history or from some investigations? That is one. Second, if could you also please elaborate on, like we have this patient with IPEX syndrome. The transplant chimerisms are dropping after 3 months, but he continues to remain clinically absolutely well. How do we explain it, or what do we do from here in such kind of scenario where the mutation is still present, but phenotypically they seem to be all right? These are my two questions. Thanks.
Okay. So coming to the second question first, I'm not a transplanter, but I'm sure you would have a lot of situations where you require a very small number of cells to prevent a disease manifestation from coming back. The classical example I can give you is a CGD gene therapy trial, where if you have approx 3% to 5% expression of the superoxide formation, your symptoms will actually be almost gone. And if you have more than 10%, you will be, the patient will be doing very well. It's something very similar to like how you have in hemophilia, where less than 1% may be spontaneously symptomatic and say expression of 10% may be excellent. They would not develop it unless bleeding, unless they have a very severe or they have a significant trauma. I'll come back to this question a little later. Coming to your first question of severe congenital neutropenia, I think some of this neutropenia which we face in clinical practice, very early in childhood, you have two diagnostic dilemma, whether you're dealing with a severe congenital neutropenia or you're dealing with an autoimmune neutropenia. The problem with severe congenital neutropenia is an autoimmune neutropenia. Sometimes it is not possible to distinguish, and sometimes the autoimmune neutropenia can be a part of an extended Evans syndrome, or it may be alone, and it may also be a manifestation of inborn error of immune deficiency. So I don't think marrow is very greatly helpful. That maturation arrest business, I think, is too overhyped and doesn't give us any particularly a definitive clue as to underlying molecular defect. So what we do at Wadesh Children's Hospital is, of course, we will do a bone marrow. There's no doubt about it. So some of the clues which we look for, if you have a neutropenia with lymphopenia, and please remember, in children, child is a lymphoid organ, their absolute lymphocyte counts are much higher. So don't get fooled by having a 2000 or 2500 ALC. It may still be a lymphopenia in an infant. So if you have lymphopenia with neutropenia, you are probably dealing with a GFI1 transcription factor deficiency. In the marrow, if you find that the myeloid element is ablated, you are probably dealing with a GCSF receptor mutation defect. The ELANE gene and the other genes are very difficult to make out very clear cut on the basis of marrow. The commonest is the Elaine gene defect. So these are two marrow clues which we look for, which will tell us about some idea about the underlying molecular defect. The other thing which we look for is syndromic features. So say for this patient, if you have if it's an adult, if the stomatitis is intermittent, right, very early in childhood, then you must suspect a congenital immune deficiency. In such a situation, examine the body, look for prominent subcutaneous vein. If you find very prominent subcutaneous vein, it will be a clue that this could be a glucose 6-phosphatase 3 deficiency. We do an abdominal sonogram in all of them to look for any renal abnormalities, and we do a 2D echo for all of them to look for any cardiac abnormalities because they are associated with a heart problem. Like one of our patients who was diagnosed as mitral regurg and tricuspid regurg at birth, following up with Vadic children for almost 18 years. He also had cryptorchidism. He also had very prominent subcutaneous vein, and he was having delayed puberty because of the cryptorchidism. Was referred to me by a very alert pediatrician for just a borderline neutropenia. And these are all the features of a syndromic congenital neutropenia like glucose 6-phosphatase deficiency. You can clinically suspect it, and one of our patients had a patent foramen ovale. So these are the clues which can tell you that you are dealing with a syndromic thing like glucose 6-phosphatase, which I think you can suspect clinically and confirm it molecularly, because giving a drug like Jardiance will remove the toxic metabolite which is excreted out through the urine, which is responsible for neutropenia. And there's dramatic improvement in the neutropenia. So I think this is roughly the approach which we follow for our patient. Look for other features which can give, of course, in cartilage hair hypoplasia, you will have the hair which is abnormal. In patients of, that AK2 deficiency, you will have deafness associated with it. So these are some clues which can tell us, and we can always open up all the causes of severe congenital neutropenia and see if any of the syndromic features are present or associated, which can give us a clue. For autoimmune neutropenia, we sometimes give a trial of IVIG and see if there is a dramatic improvement in the absolute neutrophil count. If the absolute neutrophil count improves dramatically, we would suspect an autoimmune. There is, I think IIH is doing an anti-neutrophil antibody test, and we try to do it. Not that we rely too much on that for making our diagnosis. Absence definitely does not rule out, and present does not always mean that there is an autoimmune neutropenia. Presence of other autoantibodies like ANA and other Coombs positivity will very often tell you are dealing with an autoimmune neutropenia. So these are some of the principles which you use in evaluating them for any patients of neutropenia, especially if you have a unilineage single line affection. We would like to do an exome for them, and please, for adults, when you're doing an bone marrow for an, say, 30-year-old gentleman with neutropenia, when you are asking for a myeloid NGS panel, you're only covering about 28 or 40 genes, or don't ask for that only. Yes, you can ask for that, but along with that, you ask for also for an NGS whole exome sequencing, which can probably help you pick up an inherited inborn error of immune deficiency.
Thank you.
Thank you, Dr. Chepsi. Dr. Jaswantini, a question.
Hello. Sir, good afternoon.
Good afternoon.
A good discussion, sir, in class. Sir, being a tertiary center, actually, we get to see many, like, all these mutations in not typically presenting with autoimmunity or in the kind of infection, sir. Like, for example, we had a 5-year-old female child who had transfusion dependency since 3 months of age. They kept treating her like thalassemia. But when we sent her for West, it showed DEF6 homozygous mutation, ADA homozygous mutation, and G6PD carrier heterozygous, sir. So such cases, like, how to go about and manage her, sir? Should we start her on sirolimus? Because sirolimus, if we start her on sirolimus, we can't put her on PCB prophylaxis because G6PD carrier. So actually, we're stuck over whether to directly go for transplant. Our only complaint is transfusion-dependent anemia, sir. No other complaints, no infection, no neutropenia, no thrombocytopenia, nothing.
Was it Coombs positive?
DCT negative, sir.
DCT negative. Was the behavior like an autoimmune hemolytic anemia?
No, sir. No, not at all. DCT was negative. ANA, autoimmune profile, everything was negative. So they kept
No,
like Tal major in a private center.
no, what I'm asking you is that was the transfusion requirement too frequent
Yeah, sir. 3 weeks once she comes for transfusion, sir. Or he
every?
stop 3 weeks once.
So that is like how you typically will see with the thalassemia or some.
Yeah, sir. Actually, we been a tertiary center. She came 2 months back. So from 3 months of age till 4 years, she kept on regular transfusion support. Ferritin being like more than 4,000, she was on Deferritrox as well.
So DEF6 will be like an phenocopy of LRBA deficiency or CTLA4 deficiency. So, you know, if the behavior is like an autoimmune hemolytic anemia with FUMS negativity, like you require transfusion very frequently every week or every third day the child requires transfusion, then DEF6 is likely to be responsible. But you would know from the exome and the type of defect whether this is a reported mutation or not a reported mutation. If
DEF6
it is,
mutations are actually.
it was a reported mutation?
Yeah, sir. Only ADA they reported as VUS, but DEF6
Okay. So
mutation.
if DEF6 is an reported mutation, then it would behave like an LRBA deficiency. So you can use abatacept and see whether that works for the child. If it doesn't work, then you can consider transplantation.
Okay, so sirolimus has no role, sir, in such cases.
You can try sirolimus.
Sir, and one more patient also we had, like say, PI3K delta. He presented at 11 years with refractory Hodgkin's lymphoma.
Yes.
He kept treating as lymphoma, but when he was refractory to 3 lines, we thought we'll take him for transplant, giving Nivo ice. But he responded to Nivo ice. So in a doubt of like suspicion, we sent him for West. It turned out to be PI3K delta.
So this is a very typical story of PI3K delta.
Now
And it is my hypothesis. I believe very strongly that Hodgkin lymphoma is not a malignancy. Hodgkin lymphoma is an immune deficiency disorder. And I have a feeling that every Hodgkin lymphoma, we should do an whole exome sequencing to look for an underlying inborn error of immune deficiency. Especially those Hodgkins where the EBV is, there is a lot of EBV viremia, which are behaving atypically, and they have autoimmunity with it. Especially, we have seen with autoimmune hemolytic anemias and other things where we would look for an underlying inborn error of immune deficiency. But I feel that every Hodgkins we should evaluate, because in India, Hodgkins come at 5 years of age, and I have seen the youngest patient at 2 years of age.
yeah,
Which
sir.
is very scary to have a 2-year-old child with Hodgkin
Hodgkin's
lymphoma.
lymphoma. True.
So this kind of situation where you have relapses of Hodgkin lymphoma, you must evaluate, and this patient would do very well with leniolisib or idelalisib and sirolimus also, and he can ultimately be taken up for a transplantation, because that would be the only curative treatment for him.
These PID patients, they don't require transplant upfront, sir. Like for DEF6 and all, we can put them on sirolimus if they're responding well.
See, when the patient is unstable, it is always better to stabilize the patient, take care of the autoimmunity, and then probably when the patient is doing well, that is the time to transplant it.
So, but transplant is mandatory for them. We can't avoid transplant just with sirolimus, sir.
In patients of ALPS and all those things, you will be able to avoid transplantation completely, unless you have an homozygous fast life deficiency.
Okay, sir.
But you will have to take an individual call depending on the one very important sentence of Dr. Stephen Holland, which I think should be applicable to everybody.
Okay.
So there was one question which was asked by an Italian chap, that what is the life expectancy of a patient of CGD patient in Italy?
Okay, sir.
So they said average life expectancy of a CGD patient is 35 to 40 years over there, right, with medical management. And what is the average life expectancy of a normal Italian person? That is 80 years.
80 years.
So this boy with CGD has to be given a lifespan of at least 80 years. And the only way you can give is by doing a transplantation. Now, Stephen Holland took it further. He said the day we realized that the mortality of transplantation was less than the mortality of treating a liver abscess in CGD, we send all our patients for transplantation.
Okay, understood.
So it will depend on the situation. In our case, treating a liver abscess is as difficult and as expensive as it could be as doing a transplantation. Sometimes when I'm treating a patient of leukemia, ALL, I've just had a patient of leukemia, I've spent 30 lakh rupees for the induction phase.
Okay.
And I wonder if that the transplant could have been done.
Yeah, understood. It depends upon individual, like
Yeah, and depending on how the results of your center and how confident you are about the, and whether the patient will come back, the expenses can be taken care of, because all the time what we are doing is we are trying to arrange funds for our
Yeah.
patients.
We are in a government center, sir, so arranging funds is like very difficult.
So we are also in a semi-government, but we also
Oh.
have to arrange funds and everything. I wish I had an AK-47, I could.
Oh, nice. So at
Cool.
least once we get to see these cases, sir, like PIDs with like varied presentation, like lymphoma or transition dependent anemia.
Yes,
like,
yes.
Like nobody comes with recurrent infections or something, sir. Like all come
Yes,
with
yes.
these things.
So one very important thing is that picture abhi baki hai. The story is yet not revealed.
Yeah.
That is the story of PID.
Yeah. Sir, last doubt. Sir, for such patients with G6PD carrier state, what to give as PCP prophylaxis, sir? Because we can't give like
You
Septran.
are a better expert than I am on that. You
Eh.
can, you see, I think
I
lot of these drugs,
I
let me tell you, lot of the drugs which are labeled as contraindicated in patients of G6PD
Yes, sir.
may actually not be contraindicated. It is very often the inflammation which causes the hemolytic episode rather than the drug itself. When the drug gets labeled just because it has been given, I would try it out, Septran itself, because it's a much simpler drug. If the patient doesn't develop hemolysis, I'm happy to continue with that.
Thank you, sir.
Thank you, Dr. Jaswantini. Dr. Radhika?
Thank you, sir, for the presentation. So this is regarding a case, sir. I have a 20 years male, a case of 22q11 deletion, DJOS syndrome, with kind of mild IgA deficiency, but preserved T cell function. The lymphocyte subset analysis is normal. He presented to us with refractory autoimmune hemolytic anemia. There was a transient response to steroids, but then the response waned off. Then we gave rituximab a month back. We didn't get any kind of optimal response. We then considered the option of IVIG, but he developed kind of suspicious press with IVIG.
Oh.
So how do we go about? The next resort what I have is to go ahead with a splenectomy. But in a case of DJOS syndrome with an IgA deficiency, doing a splenectomy means it's kind of knocking down the whatever reserve immunity is there. So I'm stuck, like, how do you go next? The only option left with me is splenectomy.
You can try, you could try other form of immunomodulation. Like you already tried rituximab, you have tried steroids, and you can try sirolimus, you can try mycophenolate, you can try.
Added MMF, sir. Just a week back, I have added MMF.
You try all those options are still available to you, just like for any other patient of autoimmune hemolytic anemia. Fortunately, your patient doesn't have a very severe T cell lymphopenia or defect. There is more of immune dysregulated effect.
Yeah.
So it's still worth trying all those things.
So he will be treated like an AHA case only, sir, in spite
Yes,
of
yes.
underlying DJOS syndrome and 22
Yes,
weeks.
yes.
So there is no role of a transplant or anything like that here, right? Unless there
is a very severe T cell lymphopenia, the thymic transplant is one thing which would probably help you.
Yes, sir. So he's being treated like an AHA only,
So
but
there is a Dr. Zainab Golwala who was working with us. Now she's at Gaush. She's in the thymic transplant group. So you can write to her and ask her whether a thymic transplantation, what would be the indication in such a situation.
But the thymic transplant is going to, okay, fine. It may correct the AHA part also, right, sir?
Yeah.
Sir,
I don't know the answer to that. I'm just saying that, it's not truly indicated, but you can talk to her and see whether what are her suggestions, because somebody who's working would definitely have much greater depth of knowledge.
Yes, sir. Yes, sir. I have a second question. This is in continuation with my previous discussant. So as per you, like we should be looking for the inborn mutations in every case of Hodgkin's lymphoma, right, sir?
Yes. Every immune dysregulatory disorder, every Hodgkin's lymphoma, every patient who behaves oddly, you must.
So I had a patient like probably like 4 or 5 months back, a case of Hodgkin's lymphoma with immunodeficiency. The lymphocyte subset analysis was showing a decreased dysregulated T cell function and all. So how different we should be treating these patients, and he had a CMV reactivation also. So what I was doing is we were giving an IVIG prophylaxis, topping up with an IVIG before every cycle of ABVD.
Okay.
Subsequently, after 4 cycles, he had a COX reactivation, and we had to stop all the chemotherapy and put him on an ATT.
Yes.
So, what extra we should be doing on these cases if a Hodgkin's lymphoma has an underlying immune deficiency?
So we will give them a lot of prophylaxis.
Yeah, we have put him on a CMB, a cyclovir Valgan prophylaxis, sir, and a Septran also.
Yeah. So one is that prophylaxis. Second thing would be that the ultimate aim would be that as soon as his Hodgkin's get controlled, it should go for a transplantation if possible.
Yes, sir. So upfront transplantation is an upfront go, right, sir? Not
Because
at
your patient is already having significant immune deficiency with lymphopenia and has tuberculosis and has already other form of problems
Yes, sir.
along with Hodgkin lymphoma. Now TB and Hodgkin's go very often hand in hand. So and if you find a monogenic defect, it will further strengthen your case to send him for a transplantation. If you don't find a monogenic defect, then this dilemma will always be that transplant say, no, we don't want to transplant him. Non-transplant say, please do.
We did a West, sir, whole exome sequencing. We did not pop up any mutation here.
Okay. So I have a recommendation. We have Dr. Vaishnavi, who is in our department. She looks at the exome herself. Whenever a clinician looks at the exome, you will probably get more information.
Yes, sir.
So you can write to her and you can send the raw data to her. She will have a look at it. And if she finds something additional, almost 10% of the exomes reported outside, we pick up something additional. Then it might probably help you.
Yes, sir. After this, West has come into our clinical practice, life has become more complicated because some we understand, many we don't understand whether we should take them as significant or not significant or so.
You can use AI for that.
Yes, sir, maybe.
Maybe that will give you a good answer sometimes.
Sure,
Because we had a very complex cytogenetic abnormality in a child with ALL who was an adopted child. And surprisingly, Grok gave me an answer by analyzing each aspect of it, which was really very nice. Probably opened up my vision much better than what I would never have been able to analyze the way it was being analyzed. So maybe we should not shy away from using help from AI. They may give us good clues for that.
But AI is all about the human work only, right, sir? This last, I mean, it's not like an automation. It is human work which
No, I'm just saying for our understanding. See, all of us have learned immune deficiency how. We have seen some patient, then we have heard this gene was found in the exome. We then find out, oh, what is this gene? What does it do? Where does it express? Where is it expressed? What is its normal function? Oh, what are its manifestation? And then always reverse engineered everything to learn. With experience, we have probably now then slowly diagnosing prospectively. So probably that's the process which is going to remain for everybody. So maybe we'll have to use whatever help we get. This is not the time where we can sit down on, and do everything ourselves. I think we'll have to all get subspecialists, somebody a Hodgkin specialist, somebody an ALN specialist, maybe somebody even in inborn error of immune dysregulatory disorder specialist. Somebody will be doing only thymic transplant, somebody hematopoietic stem cell transplant in immune deficiencies. Every transplant would have its own peculiarities. If there are transplanters, they would know the answer to all these things.
Thank you, sir.
Thank you, Dr. Radhika. Dr. Gopinathan?
Yes, sir. Good afternoon, sir. Thanks for the nice discussion. So I have a young lady who's in third decade of life. She presented to me with warm autoimmune hemolytic anemia. ANA is 3+ course positive, but she has also got this viral warts, genital viral warts, and which is HPV positive.
Okay.
So kind of warm autoimmune hemolytic anemia and viral warts. First we were thinking it is just an immunosuppression related viral warts, but then it is so refractory that it is not going away with any form of therapy. We sent a whole exome sequencing that came out to be negative. So how should we further work up this lady? Some refractory warm AHA with viral warts.
So definitely one should look for an inborn error of immune deficiency. With ANA positivity, there is a possibility that the patient might evolve into a lupus-like thing over a period of time. And I would even consider doing an whole genome sequencing for her, because some of the intronic variants, some of the copy number variation cannot be picked up by whole exome sequencing, and probe further, because here I feel that yes, this particular patient definitely needs to be probed further, because she's got an immune dysregulatory disorder and she's got a refractive wart. And wart, for wart, CXCR4 is very important, plays a very important role in that. And EVER1, EVER2, SIB1, these are very important genes, and sometimes they may not be present only in the hematopoietic system. They may be present in the cutaneous mutation may be there in the cutaneous system. So, it's possible you can have this thing. Plus, other thing which, as we were talking, we are not looking at the somatic mutation. If there is another project which we have in mind, is that for all patients of even single autoimmunity, including an ITP which is behaving like a chronic ITP, one should do a 500x plus exome sequencing to look for somatic mutation. I'm sure there are somatic mutations which are responsible. Nobody has any business to get and autoimmune processes just like that. There must be something wrong with the regulation.
So for this lady, I would additionally ask for whole genome plus
Whole genome, yes.
plus cutaneous. You were telling something, the skin fiber.
Yeah, but here it's looking more that she might evolve into a lupus also. Now there are some monogenic cause for lupus, so you can ask your lab which did your exome to look for monogenic cause of lupus also. That might also be worth looking at, like TREX1 and all those things. But
Right.
ultimately, lupus is also an interferonopathy.
Okay, fine. Thank you, sir. Thanks for that insight.
Yeah.
Thank you, Dr. Gopinathan. So there is one question from the audience.
Yeah.
From Dr. Jemina Davis. She has the patient, 29 years old male, inflammatory bowel disease since 17 years of age, generalized lymphadenopathy, hepatosplenomegaly, bronchiectasis of right middle lobe. The duodenal biopsy shows chronic duodenitis, colonic biopsy shows chronic colitis, lymph node shows reactive lymph node. There is a chronic ulcers in the left leg, which is put to be granulomatous, but TB has been ruled out. She has got double negative lymphocyte subset analysis shows double negative T cells in the range of 2.6%. Genetic analysis shows NRAS heterozygous mutation positive. What would be the line of therapy? Will sirolimus help in this patient?
So I don't think that double negative T cells of 2.6% is significant. For the Indian population, we need a higher double negative. And you have not mentioned whether it's T cell receptor alpha beta or gamma delta. So if you have a T cell receptor alpha beta double negative cells of more than 3 to 4% is what we take, then we think in terms of ALPS, right? Now, NRAS heterozygous mutation, you can have a rasopathy. I don't know whether you can try sirolimus in this, but if you look at the symptomatology of your patient has got lymphoproliferation, has got infection, and patient has got IBD-like manifestation. So, considering the age, I would think of a CTLA4 deficiency as a very strong possibility in this patient, in which situation sirolimus can help you. Sometimes when you don't see the CTLA4 mutation in that, once again, as I said in the previous question, you can do a whole genome and see whether you can pick up that, or you can ask NIH or some lab, whether PGI, they can do a CTLA4 expression. So if the CTLA4 expression is poor, then probably you can think of a CTLA4 deficiency, because this is a very typical, lymphoproliferation, autoimmunity, you have infection, especially bronchiectasis, lung infection, and IBD-like manifestation, which is very characteristic of this kind of group of immune dysregulated disorders.
Thank you, sir. Another question is from Dr. Yimon Tent. What clinical clues should raise suspicion for an inborn error of immunity in adults? Number one. Number two, what are the key laboratory investigations you must use in the initial screening for suspected inborn errors of immunity?
Okay, so I think whatever when I mentioned to you during my talk is applicable to all age group. So the principles remain same, whether it is a child or it's an adult. Anybody who comes to you with even a single episode of life-threatening infection, you must evaluate this patient for underlying inborn error of immunity. Somebody who comes to you with recurrent salmonellosis, somebody who develops a non-tuberculous mycobacterial infection confirmed, you have no business to get a non-tuberculous mycobacterial infection. If you get, you are immune deficient, you have defect in IL-12, 23 interferon gamma loop defect, or you have a defect in NADPH oxidase, that is your CGD. So you must evaluate this patient for underlying immune deficiency. So any infection, right? Severe, there are specific immune deficiency which make you susceptible to CMV. So if you have somebody coming with a recurrent CMV, you cannot ignore it. You have to evaluate whatever may be the age group of the patient. Even if it's a 50-year-old lady or a 50-year-old gentleman, you have to evaluate them for underlying inborn error of immune deficiency. So besides the routine thing, like somebody comes to you with a chronic giardia infection, recurrent giardiasis, is a very important clue. Some of the patients who are evaluated for diarrhea, they look at the globulins are low, 1.2, 1.5. They are CVIDs. You cannot work them up from the GI tract, colonoscopies and this thing. They are CVIDs. You have a globulin which is low, you do the immunoglobulin. That is the first investigation you need to do. So from infection point of view, any infection which is severe, any infection with an organism like nocardia, if you get a nocardia abscess, is immune deficient. There cannot be a patient who have nocardia just like out of the blue. Burkholderia cepacia in a non-ICU setting. In the ICU, you will get Burkholderia in the water, which is supplied for the oxygen. But in a non-ICU setting, if you get an Burkholderia cepacia, you have to think of immune deficiency. If you get an aspergillosis in a non-neutropenic setting, no steroid given, you have to rule out an underlying inborn error of immune deficiency. So these are some telltale things, a liver abscess, a lung abscess, an osteomyelitis, whatever the age group. And whether it is Serratia marcescens or it is Burkholderia or staph, you have to look for underlying inborn error of immune deficiency. These are dictums which has to be followed. So this is from the point of view of infection point of view. There can be many more in this, which I can go on, and infection which is difficult to clear, infection at unusual site, unusual organism, fungal infection, chronic mucocutaneous candidiasis, at whatever age, you have to look for underlying immune deficiency. So this is from the perspective of infection. Coming to immune dysregulatory disorder, if you see a patient with more than one autoimmunity, for me, even one autoimmunity, but more than one autoimmunity in a patient, 50% of them have an underlying monogenic defect for immune dysregulation. So whatever the age group, you must evaluate them for a monogenic defect if there is more than one autoimmunity in a patient, in a family. So this includes an Hashimoto's, which is a very common problem in our country. So you must evaluate them. It is very rewarding to evaluate them further. And as far as malignant process is concerned, if there is a family history of malignancy, if there is an EBV-driven lymphoproliferative disorder, every patient should be evaluated for underlying inborn error of immune deficiency. As I told you, Hodgkin's lymphoma, definitely you must evaluate. And I told you about the family history. Yes, family history. And if there is an associated autoimmunity with malignancy, you must evaluate for underlying inborn error of immunity. So this is from point of view of malignancy. Every HLH should be looked for an underlying primary cause for HLH. And HLH may happen not only because of a primary HLH genetic defect, but it can happen with any immune deficiency. You can get an HLH-like manifestation. You can have genetic susceptibility to EBV, which present with the fulminant EBV infection, which is nothing but an HLH. So XLP1, XLP2, we have seen XLP1 present at the age of 30. So that's a group which you should also evaluate from malignancy ones, HLH ones. Then all IBDs must be evaluated. Crohn's, ulcerative colitis should be evaluated for underlying inborn error of immunity, which you may find, you may not find, but it is worth that money to spend to evaluate for underlying inborn error of immunity in patients of IBDs. In cardiac disease, if you have special translocation of the, I mean, the great arteries, then DGOS should be looked at whatever age group. You just heard somebody having a DGOS at the age of 21. So diagnosed with autoimmune hemolytic anemia. So it can come with any age group. I'm sure the more we will probe, we will come to know more about it.
True, sir. Thank you, sir. Another question is from Dr. Ramaswamy. 12 years old boy, IgA deficiency with autoimmune enteropathy, autoimmune hepatitis with skin itching, plus immune thrombocytopenia, delayed puberty, growth retardation. What next to be done? And
Exome. Besides the immune workup like immunoglobulins and the extended lymphocyte subset analysis, I think this patient needs a whole exome to look for, because the child is already having enteropathy, hepatitis, IgA, which is on the lower side. I don't know about the IgG, IgM. You should do antibodies, ability to produce antibodies against tetanus toxoid, pneumococcus, against hepatitis B, to see whether there is an ability to produce antibodies to protein, to glycoproteins, and to polysaccharide antigen. You should do the blood groups, anti-A, anti-B, depending on what the blood group is, whether you can produce anti-A, anti-B or not, depending on what the patient blood group is. So I think there's a lot. This patient is definitely immune deficient, undoubtedly.
thank you, sir.
Because the IgA deficiency will not cause so much of infection also. If there is an infection, then you must look for an associated IgG2 deficiency.
Thank you, sir. Another question is from Dr. Mukul Agarwal. Can you please expand on leukemia and lymphoma which predisposed in the IEI settings and how late they can occur? What are the subtypes and so on?
Okay, so one of the classical inborn error of immune deficiency which I talked to you was the GATA2 deficiency. And all of you should know what the story of GATA2 deficiency is. It was initially first reported as a cause for familial acute leukemia or familial MDS, and this was done in an ASH presentation on Friday, or I think Saturday. On this plenary session, presentation was being done. And that's when GATA2 was found out as a cause for familial acute leukemia, acute myeloid leukemia. That time in the audience was a gentleman named Stephen Holland, and Stephen Holland had a group of 57 patients of a syndrome which was called as monomax syndrome. And in that, there was monocytopenia and there was susceptibility to tuberculosis. And some of these patients had family history of MDS or leukemia in them, along with an AIDS-defining illness-like presentation with NTM, non-tuberculous mycobacterial infection, with cryptococcal meningitis, and so on. And so some patients had lymphedema, some patients had pulmonary alveolar proteinosis, some patients had stroke, venous thrombotic manifestation, your warts and all those things. So this patient was, when Stephen Holland heard this, he said, oh, this patient has a family history of MDS and AML. So he called up his lab and told them to sequence all of them for GATA2. And to his surprise, each and every patient had a GATA2 mutation. So this is how GATA2 escaped. So GATA2 will be the first thing. And if you ever attend the ASH meeting, I haven't attended the ASH for last 4 to 5 years, but before that, when I used to attend, there used to be a session on Friday, Corporate Friday, or for familial leukemia. So if you attend that familial leukemia where you have this thrombocytopenias and neutropenias and other things which come with familial leukemia, you will be surprised that they believe that almost 70 to 80, 60% of patients in adult with leukemia have a familial leukemia. It was too high for us to comprehend at that time that you can have so many patients. The implication being that yes, this patient would require a donor for transplantation. The donor should not be a silent carrier when the patient is not yet manifested the disease. The other gene which I would look at is TET2. Now we all know TET2 is a very important genetic abnormality, which is a somatic mutation which is found in CMML, myelodysplastic syndrome, acute myeloid leukemia, ALL, myeloproliferative neoplasm. So these patients, TET2 germline mutation, the first presentation can happen at the age of 55, 60. the first patient of TET2 heterozygous mutation, germline presenting with an acute myeloid leukemia was presented by Germany, where they found 2 members of the family in the 5th to 6th decade having an acute myeloid leukemia with the same TET2 mutation. And that's what tells them that this is not somatic, this is probably germline, and they went on to do the studies from the endoderm and the mesoderm to find out that this was a germline mutation. Now there are germline TET2 mutation. We have 2 or 3 patients of germline TET2 mutation. Both of them have presented at the age of, one at the age of 55 with an EBV-driven lymphoproliferation process. Another patient who was presented at the age of 44 with EBV LPD, then went on to develop an anaplastic large cell lymphoma, and then subsequently died. We could not, and we could have been the first one to describe the TET2 mutation germline, but that was not included in the PID panel, so it was not reported. So this is TET2 is another important germline mutation which can come. Then you can think of there are a lot of genes which have to do with your DNA recombination, the RAG1 and subsequently downward RAG1, RAG2 mutation, and which can come much later on with susceptible leukemia. For lymphomas, all genetic defects which make you susceptible to EBV, like XLP1, SAP deficiency, XLP2, ZAP deficiency, fast ligand homozygous. We have seen 2 patients of fast ligand deficiency, one presenting like a leukemia at the age of 10 months, and WBC count is 1,26,000. It is only if you have seen the peripheral smear, you will realize that these are not blast cells, these are all mature lymphocytes. So if somebody doesn't tell you the age, you will say this is chronic lymphocytic leukemia. In a child who is 9 months old, you will not diagnose CLL. And that's when when Dr. Manisha, I think, did the flow cytometry, she found 86% double negative T cell. And this patient had a homozygous fast ligand deficiency, which was worked up by a Paris group, Dr. Frederick Lecoq. And so you need to keep yourself, wherever there is a family history, wherever there is association of autoimmunity, wherever the response to medication is either too dramatic or too refractory, start suspecting these conditions. And especially when you have associated infection, autoimmunity, they're or HLH, severe immune dysregulation. And there are a host of other genes which can be involved in, we all know now that IDH1, IDH2, and all of them, DNMT3A, right? Now DNMT3A, there is a genetic mutation, germline mutation, which can present with various form of ICF syndrome. So it is the more you will look, the more you'll find. I'm sure about it.
Thank you, sir. Dr. Vinayak Chikodi, your question, please. Yeah, Dr. Vinayak.
Sir, your comments on nitroblue tetrazolium test.
Wonderful test.
Nitroblue tetrazolium test.
It's a wonderful test. It is done correctly. It is even better than doing a DHR for CGD.
Okay, thank you, sir.
Yeah.
Thank you, sir.
Yeah.
So if the patient...
Because this was one of my thesis topics during my MD.
Okay. So it's a lovely test. Simple and beautiful test.
Yeah, exactly, sir. But I had literally forgotten about it. So I said, let me just... Thank you, sir. Thank you.
Yeah.
Thank you.
Thank you. Yeah. Anybody has any other question? Because I've finished all the questions from the audience. Well, sir, so in that case, it's time to move. Thank you so much, sir, for that wonderful lecture. Fantastic lecture, as always. Good to hear from you. Good learning from you, sir. Always. Thank you so much.
My pleasure. Thank you so much. Yeah.
And I thank all our discussants and audience who joined us today. And a very special thanks to our chief guest, Dr. Ankush Jindal, to be as a part of our panel. Thank you so much once again.
Thank you.